Good morning. My name is Dr. Louis Lambiazzi. I'm the chairman of the Department of Medicine here at the UT College of Medicine in Chattanooga. I'm a gastroenterologist, and this is Grandrounds. I'm giving it to the biggest audience I've ever had, which is nobody, but it's life during COVID, so this will be available hopefully on the internet later, and will be available for those of you who are streaming right now. So today I'm going to take a little bit of a break about worrying about COVID and the coronaviruses and virology and ICU that we're all seeming to do right now, and I'm going to talk a little bit about pharmacogenomics, which I think will be very useful when we start coming back to some sort of normalcy. I think that there are two trends that are going to influence the way we practice medicine in the 21st century. One was artificial intelligence and machine learning and the use of computers to try and help us aid in diagnosis and treatment and that sort of thing. I've spoken a little bit about it. We also had a much better Grandrounds by my colleague from University of Tennessee, Chattanooga on mathematical modeling. And I think the second topic is this idea of precision medicine, or tailoring the medicine to the patient, and using genetic information to try and be better both in terms of treatment and diagnosis. I think the area of this that's actually probably the closest to ready for prime times is pharmacogenomics, and pharmacogenomics is the use of genetic information about a particular patient to try and determine whether or not a drug will work, essentially, or to try and see whether or not we should use a particular pharmaceutical in that patient. This is really taken off in oncology, but there are other areas where there's substantial data about this. And as I go to conferences around the country and I talk to people around the country and I talk to people who various health systems that are rolling out programs looking at this in their health systems, one of the things that they say is that the biggest barrier to implementations is that physicians don't 100% understand this and are reticent to adopt it. So I think there are going to be a series of lectures. This today is the first, going over various pharmacogenomic topics and introductions, so that when we're approached as practicing physicians by our colleagues in pharmacy, et cetera, about these issues, at least we'll have a passing familiarity with it. So let's get started. So today we're going to talk about pharmacogenomics, and basically the idea is that structure of the patient determines the function, and that structure varies among individuals, and therefore function varies among individuals, so drug metabolism varies among individuals. This is not anything earth-shaking. Anybody who's practiced medicine for more than 5 minutes knows this. I want to give special thanks to Dr. David Hurley, who's a professor at East Tennessee State University, who donated most of the slides that you'll see, the ones that are backgrounded in black, and Cameron Thomas in the College of Pharmacy in the University of Florida, who has some slides towards the end about clopidogrel, and I'll tell you, but I wanted to thank both of those people and acknowledge them. So this is what I was talking about. Not all drugs are effective in all patients. You know, some of the drugs we see are actually pretty... Hello? A lot of the drugs that we see are reasonably okay. You know, analgesics, COX-2s, about 80% effective. Drugs for asthma, drugs for arrhythmia are effective, but also not effective in all. Even if a drug is a pretty good drug, it's still sometimes just not useful in some of the patients. And you can see here's a list of all the drugs, and then of course, you know, Alzheimer's disease and cancer. Actually, hepatitis C now would be way over here in the 100% range. But you can see there's a big variability among patients, and it would be nice to know beforehand, is this drug going to work? Is it going to be more likely to cause complications, et cetera, et cetera? So, obviously, anybody who walks around knows that there's an exceptional variation among people, that every one of us is genetically different from every other human who's ever lived, except for monozygotic twins. And, you can see these are both humans, but one is much taller than the other and much smaller. Even, as it turns out, even monozygotic twins that are probably genetically similar, there are probably epigenetic dissimilarities. So really, no two person is exactly 100% correct, identical. Although monozygotic twins are probably the most identical that there are. So 2 random humans are expected to differ in about 1 in every 1,000 nucleotides, so 0.1%. So the human genome is about 3 billion nucleotides, so there's probably an average every 2 random humans different at about 3 million nucleotide positions. Most of the changes are neutral. They don't have any real functional difference, but some influence function. Some are functional and influence phenotypic differences between humans. Why do people tend to run towards heavy? Why are they predisposed to diabetes? Why are they able to metabolize certain drugs? It's estimated there are between 5 and 10 million unique SNPs, and I'll tell you what a SNP is in human populations. So what is a SNP? A SNP is a single nucleotide polymorphism. Basically, you know how the genetic code is made up of 4 letters, G, C, A, and T, and then this is where a SNP is a change in a single nucleotide that's common in a population. If you're the only one that has the change, that's just a mutation that you have. But really, when we talk about SNPs, we talk about things that occur relatively frequently, so we know what the function is and what the protein is downstream. So it's about 1%. About 1% of the population, they're SNPs. And so these are this is how we talk about SNPs. This is when you'll see a report. So there are 2 examples here looking at 2 genes that code various pharmacogenomic related genes. The first one is the letters and numbers identify the gene. So this one is vitamin K oxidoreductase complex 1. And then this is CYP, cytochrome P450, family 2, subfamily 2, number 9. And then the numbers indicate the nucleotide position in the gene given by a reference sequence. So the human genome has now been characterized, and there are each nucleotide position is in each gene is characterized, and this is the nucleotide position in the gene. So this is the gene, this is the nucleotide position, and then this is the wild type is for this VKORC1. The wild type is G, and then the SNP is G changed to A, and then in the CYP2C9, this is the gene, and this is C changed to T, and then then this is this star.2 is an older nomenclature, and basically what they do is they talk about different alleles, and they talk star.1 is the normal or the wild type allele, and then other alleles are described sequentially after that. So you'll see later that there'll be like CYP2C19 all the way up to star 19, for example. So the interesting thing about this is, when I went to medical school, when Earth's crust was cooling, they were talking about how, there was only the coding part of the DNA, which is the exon, and everything else was junk DNA. Well, it turns out that's not true. There's tremendous information in the non-coding parts of the DNA. So a SNP in the coding region changes a protein. A SNP in the intron changes splicing kinetics, or the way that the gene is rearranged for transcription. A SNP in a promoter region would change transcription kinetics, and then if there's a SNP in the 5' or 3' ranges, will change histone packaging of chromatin and other effects, and probably things like epigenetic effects like DNA methylation that are really beyond the scope of my understanding, frankly, and also this lecture. So you can see these are the different areas. These are the exons. This is the intron, and then this is a promoter region, and these are the 5 and 3' ends. So just to give you an idea of the various kind of variability that there are in people, that SNPs are about 93% involving a single base pair. There's also a deletion and insertion polymorphism where there's a loss or gain of several nucleotides as a group. So TCCTA would then be replicated as TA. This is about 7% of the variations. Then there's short tandem repeats where there's a repeated sequence like CCAC repeated times 8, and that's about 0.4%. And then there are other variants where there are other substitutions. So you can see this gets very, very complicated, and that's why actually a lot of the big issue now is in data processing. How do you make sense with this, and the need for big computing to tell us how to do this, because in my poor little brain that's clogged with song lyrics from the 80s, I can't remember each and every one of these. So there are databases now, and there are things to help us with decision making. But it's interesting that all of the data created by genomics since the year 2000, when the first human genome was sequenced, is more than all of the data created previous to that by all of humanity. So it's just a huge amount of data and a huge amount of things, and that's why precision medicine genomics is dovetailing with AI, because we frankly don't have the bandwidth to comprehend and use all of this. So one of the things to talk about is that the variation among individuals is basically the sum of all of these changes, and at each difference, for our topic, each difference may influence the activity of an enzyme that's used to metabolize a drug, a receptor that's used to the drug by which the drug asserts its action, or binding by a transport protein, or any of the multiple aspects of the metabolism. And this turns out to be polygenic, so there's an influence of many genes. And so the point of this is that there's a lot of variability, there's a lot of stuff that's been described, and there's still a lot of stuff that's not known, and it's very, very complicated. So you have to take it's like practicing medicine. It's an art. There's just more information, but nothing is 100%. There are very few things that are 100%, and obviously the ones that are 100% will show up on board exams, and everybody will talk about them. But in the real world, we have to still look at all of the patient, look at the variability, get our sense of what's going on, and make a decision as a doctor. But hopefully one day we'll have better tools to at least tell us the difference about how people are going to behave. So this is the goal of personalized pharmaceuticals. Was first described in 1959, and the goal was to use pharmacogenetics and pharmacogenomics to identify human variation in administered compounds, and these variations are being identified now. There are guidelines. There are a large number of drugs that actually have labeling recommendations about looking at various genomic information, and right now, and there's a large number. There's a group called CYP, which gives guidelines for the use of this information in prescribing. And I think that this is going to be very important in practicing in the future. It's interesting, United Healthcare, one of the big insurers, has decided to now pay for genetic testing in people who have failed one antidepressant, because there's very good data that using some of the genetic information you can better tailor the use of antidepressants. So this, I think, is beginning to come in mainstream, and that's why I've decided to speak about it today. So let's just talk a little bit, and this is not rocket science, but it's the conceptualization of what's going on. If you look at what you're looking at is down here is efficacy, the pharmacologic effect of a medicine. So you're going to give a drug, prescribe a drug to a patient, and the first thing that happens is the drug has to get into the patient, has to be distributed, and has to be metabolized, has to be ready for action, right? So these are the pharmacogenetics of the drug. This was something that for me was a 1.5 hour of lectures in 1 week in medical school. But this is actually very important. And there are, of course, genes that determine whether you absorb or distribute or metabolize the drugs, and then the variants of these, the genotype expresses the genes, which then helps regulate the pharmacogenetics of the drug. And then the other thing is basically the pharmacodynamics in response, right? So once the drug is delivered, it has to its site of action, then it has to actually do what it's supposed to do, and then there are also genes that regulate that, and there are variants on those genes, and then that'll tell you whether there's efficacy or toxicity. So this is where we're talking about. These genetic variants influence these two things, and so it becomes kind of important to figure out where you can identify polymorphisms and their possible effects. So they can be enzyme transporters, receptors. They can be there are different phases of drug metabolism, and we'll talk about it for a second, and then whether or not it's in the pharmacogenetics or actually pharmacodynamics, or whether the drug actually works. And then, so you can talk about an individual, so we know that for certain drugs, you can actually measure some of these things in an individual, and then also in populations, that their variation may exist. So carbamazepine toxicity is much higher in Asians because of a variation in a high frequency of a variant allele in one of the cytochrome P450 genes. Another sort of classic is alcohol dehydrogenase variability, also in Asians, causing adverse reaction to alcohol, or some of my friends who turn bright red like a matchstick when they have even one beer, and that's because of the genetic variability and difference in metabolism. Fortunately, that doesn't affect Irish Italians as frequently. And then, of course, which drug, you need to know which drug is affected. So you need to know all of these things, and then what disease. So, this is just another way of beating this into the ground. You have a compound that's got all of these metabolisms. It gets concentrated, it goes to the receptor, and then it's metabolized, or it works its effect in the cell, and then you either have an adverse or a beneficial effect, and you can get a gene that interacts on all of these areas. And this just goes to show you that you add a different level of variability into all of this. So if you can have both variants in the way that people metabolize the drug, and also in the efficacy. So you can have people who metabolize the drug poorly, and they have more likely to have toxicity, or you have people who metabolize the drug normally, and then they'll have normal efficacy, and it can be on both. And so there can be a drug receptor spectrum of response, and it really depends on your makeup. So there are two things to think about. Is there a resistance at the receptor? Is there resistance at the effect part, or is this a metabolism issue? And so one of the things that you have to do is you have to understand how the drugs are metabolized and how they get delivered. And so this takes us a minute away from just knowing that this drug is good for this condition, but actually thinking for a minute of how is this drug going to be absorbed? How is it going to be metabolized? Are there things that interfere with it? And so we have to have a little bit more thoughtful approach to our prescribing. So if you look, there are some drugs that basically get absorbed, and then they get conjugated, and then they get eliminated. There are some drugs that have to be metabolized into an active and inactive metabolite. Clopidogrel is an example that we're going to talk about, and then they get conjugated and excreted. Some drugs just get excreted completely as they were, and not conjugated and not metabolized, and then usually the drugs they're administered are lipophilic, and then excretion is hydrophilic. There are some drugs that obviously are excreted in the bile that are more hydrophilic, but in general, those that are excreted in the urine are more hydrophilic. So, and these are different enzymes where you can see alcohol dehydrogenase, which is one of my personal favorites. The cytochrome P450s that we're going to talk about in a little bit, these are phase 1 that basically metabolize a lot of the medicines. And then phase 2, these are the ones that they use for conjugating and changing the polarity or hydrophilic properties. These are more focused on excretion or elimination of the drugs. So here are some examples of specific drugs that can and where they are. So isoflurane gets basically excreted unchanged. Succinylcholine basically gets changed to inactive metabolites, and then so it gets inactivated, and then the inactive metabolites are eliminated. Lorazepam gets conjugated to inactive metabolites and then excreted. Acetaminophen, there's a reactive metabolite. This is where you get into trouble if people are overdose in acetaminophen, and then the rest then it gets converted to inactive metabolites, and then they're excreted. And Prozac gets changed to an active metabolite, and then the active metabolite is excreted. So if you have a change in enzymes in any one of these areas, you can either build up inactive metabolites, which may have toxicity, or you cannot have an active metabolite in the case of Prozac, or you could be slow to get rid of succinylcholine, just as an example. So where are a lot of these genetic polymorphisms? Well, you can see there's a ton of them. This is sort of old. I'm sure that there are more of these now, but a lot of them are in the cytochrome P450 system, which is over here. And then you can see there are other ones that have been described, TPMT. Those of you who are in oncology or gastroenterology or rheumatology know about this one for thiopurines, but you can see that there are all of these various polymorphisms that are, with the most common being this CYP3A 4, 5, and 7s that are the most common in the population for phase 1, and the glucuronyl transferases in the phase 2 enzymes. So let's talk a little bit about cytochrome P450, because there's a lot of decent data right now. There are other areas that may be important, but there's a lot of data that right now. So let's talk about cytochrome P450s. They're all heme-containing electron carriers. They're usually in the hepatocytes in the liver, and they have a critical role in electron transport in the mitochondria, and then in the endoplasmic reticulum, they carry out metabolism of xenobiotics, which are basically pharmaceuticals. There's foreign chemicals in the body, but including the drugs that we prescribe. So there are 58 cytochrome P450 enzymes grouped into families and subfamilies, and they're inducible. So we've all seen this. Our patients that are on multiple medications or drink a fair bit, they're harder to sedate, for example, and that's because of the inducible nature of the cytochrome P450. And then they work primarily in the master organ, which is the liver, where cardiologists, where the blood and circulation allows the chemicals to accumulate. So just to review, a SNP is a change in a single position. And because each gene can have many SNPs, all of the regions containing one gene are called an allele. So, and then a particular pattern of SNPs found in a single allele is called a haplotype, and haplotypes are designated as star 2, star 3 to designate variations from star 1. So you can have CYP2C19 star 1, which means that you've got a normal or wild type CYP2C19, for example, whereas if you have CYP2C star 17, like we'll see in a little bit, then you're ultra rapid metabolizer. So that's just the terminology when you see it. And each individual has a diplotype, which is 2 haplotypes, right? So star 1/star 5. So this is just what they'll look at. If you're going to do if you get a pharmacogenomic report, they abbreviate it as PGx, and you get a haplotype, a diplotype, and then there'll be citations about research about what this means about the metabolic phenotype, and then a therapeutic recommendation. And we'll go through this a little bit. I'm going to share my own pharmacogenomic data with you towards the end of the lecture. So the exposure depends on the drug. So if you're a poor metabolizer, for example, what happens is some people who are poor metabolizers are less likely to have the drug effect. Some are more likely to have a drug effect. So if you're a poor metabolizer, you actually have a bigger drug effect, whereas if you have so if you're a poor metabolizer, you'll have of some drugs, you'll have a higher level of the drug and a higher level of effect, and some you'll have a lower level of effect. So if you have a poor metabolizer on warfarin, for example, if you don't metabolize warfarin, you have to use less warfarin in those patients because they have a higher effect. And if you're a poor metabolizer of codeine, then you basically get too little efficacy and you get too much toxicity, actually, if you're an ultra-rapid metabolizer. So I kind of butchered that, but basically, just because you're an ultra-rapid metabolizer doesn't necessarily mean that you're going to get less effect of the drug. You might get more effect of the drug, but you also might get, and just like if you're a poor metabolizer, you may get more effect of the drug or less effect of the drug. It depends on where the defect is and what the metabolism is doing to the drug. So, like I said, these are the top 5 variable CYPs, CYP2C19, CYP2C9, and CYP2D6 are the most variable in terms of the cytochrome P450 variability. And you can see, like a CYP2C19, which is important in clopidogrel and in proton pump inhibitors, there's about a 14 to 44% are normal in metabolizers. 20, about 30% are intermediate, about 20% are poor, and then about 30% are ultra rapid. And CYP2D6, for example, is important in pain and SSRIs, and you can see the data here. So, one of the nice things is that there's a ton of research that goes and shows where the pharmacogenes may influence outcome. And so, like I said, CYP2D6 is important in pain management, SSRI, CYP2D6 and CYP2C19 are important. Same ones are important for tricyclics. CYP2C9 and the vitamin K, VKORC1 is important with warfarin. Phenytoin it's got its own things. Thiopurine methyltransferase, tacrolimus is in part moderated through the CYP3A5 gene. So these are very, very well worked out areas, and these are areas where there actually are current recommendations for checking or for considering to check genotypes when prescribing these drugs. So just to go over some of these, so clopidogrel or Plavix, poor metabolizers exhibit higher cardiovascular event rates at recommended doses. So CYP2C19 testing is widely available. Some places have done it as point of care in the cath lab, and I'm going to share with you some data as an example in a few slides. Codeine, the death related to ultra-metabolism of codeine in children post-tonsillectomy or adenoidectomy. So we don't use codeine a whole lot anymore, but CYP2D6 testing can help predict whether somebody's an ultra-rapid metabolizer. Tramadol, which we do use a fair bit, if somebody is a CYP2D6 ultra-rapid metabolizer, there's been a higher increase of death due to this hyperactive metabolite. abacavir, HLA screening can be used, and then carbamazepine. Also, there are HLA types, especially in Asian ancestry, that can be associated with increased toxicity. So these are all areas that have PGx information actually within their labeling right now. So, and then there are just variations among various ethnic backgrounds. So about 1 in 300 Caucasian people will have variations in thiopurine methyltransferase, or TPMT. So you have to be very careful with mercaptopurine and azathioprine, whereas it's 1 in 2,500 Asians. If you look at N-acetyltransferase, 52% of white Americans, but 17% of Japanese have abnormalities where they have an enhanced drug effect. So drugs like isoniazid, hydralazine, and procanamide have to be changed as well. And then there are things like Gilbert syndrome, which is in about 11% of white people because of glucuronal transferase abnormality changes, the way the body handles bilirubin. Etc. So there is a CYP and I forget what causes the acronym, but CYP basically gives the online reference. So you can actually go to the CPICPGx.org, and you can find out, understand how the available genetic texts, how they should be used to optimize therapy. It's not whether the test should be ordered. So that's up to the clinician, but I just wanted to make you aware that the tools are out there. I think that we're looking right now at rolling out getting PGx data available for our patients through Epic, and so I think in the not too distant future we'll be faced with having another screen to look at when we're prescribing about pharmacogenetic data. But some of this stuff I think could be very helpful in how we choose to use the medicines that we treat for our patients. There are also some other pharmacogenetics that are available. This PharmGKB.org is a very good source for pharmacogenomic data, in case you ever wanted to spend a few minutes of me time reading about it. It's interesting, if you sit and you think about this, they evaluate clinical trials with a number needed to treat. So if you had a new condition and you gave a medicine for that condition, and the number needed to treat was 5, you would think that was spectacular, right? I mean, that's a spectacular result. That's very significant. It's all great. But it also means the drug doesn't work in 4 people, right? 4 out of 5 people, it doesn't work. So the hope is that eventually we'll be able to predict dosing, we'll be able to predict effect, we'll be able to predict whether the right test is. And this is basically what people are trying to do. And you can see this is down from Duke University. And they've been trying to work on this for years. So let me show you what this might look at. So that's sort of the background data on this, and sort of a very high level view of sort of the concepts involved in pharmacogenetics. Now I'm going to start talking about some of the details, and I think going forward for the next series, probably be 2 or 3 more talks on this. We're going to talk about specific areas and specific areas of research. But actually, for the last couple of years, I've been attending the UF Precision Medicine course. It's in February in Orlando, which isn't really a hardship. But basically, last year they did for free everybody's pharmacogenomic genotype. So this is mine, and I'm sharing it with you. But here are some of the things. So you get a report like this. So here's the gene. So CYP2C19, and you can see my genotype is *17*17. So that's actually my alleles and haplotype. So I'm actually an ultra rapid metabolizer. So what does that mean for me? So it actually means clopidogrel would work better for me, because clopidogrel is a prodrug. It has to be metabolized to a prodrug. So I actually have a slightly increased risk of bleeding on clopidogrel. Voriconazole probably would be metabolized a little bit better. And I probably have an impaired response to proton pump inhibitors. So I'm going to be, not only am I a big boy with reflux, but I'm probably going to have to be on BID, Nexium, or dexlansoprazole or something like that because of the multiple PPIs. So my CYP2C9 genotype is normal, but it's interesting, my vitamin K, I've got a reduced warfarin sensitivity. So basically, I may have to be, if I ever had to take warfarin, I may have to have a little bit of a higher dose of warfarin. And actually, there is a CYP guideline for Pharmacogenomics Guided warfarin dosing, which was published in 2017. And so if one of my physicians ever needs to give me warfarin, I hope they'll look at that. CYP2D6, I'm a normal metabolizer, so pain medicine and all of that stuff should work fairly well without undue toxicity. I have normal activity in TPMT, and then it's interesting, my CYP3A5 I'm a poor metabolizer, so I may have some problems with tacrolimus, and so if I ever have to get a transplant, I'll make that available to the people that are prescribing the drugs. And then the other part that's interesting in this, and I think that you have to, it's like all tests we look at, we have a tendency, especially when we're busy, to look at a number and think it's real, but you have to sit and think, how good is this test? How good are we able to, how do I know what I know? And so it's like in a financial report, they always say the bodies are buried in the footprints. It's in the footnotes. The same thing is here too. There are always footnotes that come with these. And so if you look at this test, so there are some tests like this one where the assay only tests for a select number of allelic variants. Other variants will default to a one or no call that are most genetically serious. So, they called star.3, but if I had a star.1, I actually might have had something else, or what they called a no call. And then this is interesting. In this one here, they can't detect, because this gene is actually it's in a harder area to sequence in the genome, so they can't call copy number variants. Remember we talked about where you have repeats of various genome things, and so they can be functional. And so if your result is a normal metabolizer, as mine is, there's a 5% chance that I could be an ultra-rapid metabolizer, and because they couldn't detect copy number variants. So a good lab will tell you where its limitations are. Some of the clinical labs would then go, and you'll see something called Sanger sequencing, where they'll go back and they'll look at the areas that they had a hard time with, and they'll sequencing them each nucleotide at a time, but it's usually very expensive to do that. It's kind of interesting because I think Illumina, so 23andMe is a very common commercially available test that people are now getting this kind of information, and they're coming to their doctors. But one of these, and I think it's CYP2D6, but I'm not sure, they can't call all of the alleles on because there's a technology from Illumina that they use to look at the variants, and Illumina can't call, or has a limitation in calling some of the allelic variants. So you have to be sort of careful with this data, and like I said, always look at this when you get a report to see what areas that they're having problems with, because not all tests are the same. It's sort of like, we know that high triglycerides interferes with certain assays in the blood, or not all tests are sensitive and specific, and you may have to repeat them, etc. So let's talk one last specific example and then wrap this up. You've been a very quiet, if attentive audience. So let's talk about clopidogrel, or Plavix. So that's used a lot of times in people with stroke or cardiovascular disease to prevent platelet aggregation and to decrease thrombotic events. And so clopidogrel is interesting because there's it's absorbed through the apical membrane of the intestinal cell, and then basically it gets transported through portal circulation to the liver cell, where it's acted on by the cytochrome P450 system and another system. Part of it is put in metabolized to an inactive metabolite and it's eliminated, but through the cytochrome P450 system, for it to work, it has to be converted into these active metabolites through the use of CYP2C19 and others, and then it basically then gets excreted into the bloodstream, and it causes irreversible blocking of platelet aggregation. So the key take-home point is that you need your cytochrome P450 system, and you need your CYP2C19 in particular to be able to metabolize clopidogrel for it to work. Right, so if you're a poor metabolizer of clopidogrel will not work as well, and people will not have the same antiplatelet effect. So where does this, and then you can see here, so 35% of patients from this one study, this is from 2009, had star 1 or the normal wild type. 5 to 10% are like me, ultra-rapid metabolizers, and then there are people who are intermediate and poor metabolizers, these star 2, star 2s, star 3, star 3. So star 2 and star 3 are actually the big ones, but taken together can be around a third of patients don't metabolize clopidogrel in a way that makes it that would affect efficacy. So there was actually a large study that was published about 2 years ago, where there were about 7 academic medical centers where they took people who were getting percutaneous cardiac interventions, and they had about 1,800 patients, and about 31% had a loss of function allele, and 70% did not. So then what they did was they and it was up to the doctor basically what to put the patient on the whole time, but the loss of function, about 40% were still placed on clopidogrel and 60% were placed on an alternative, and then the non-loss of function, about 85% were put on clopidogrel and 15.5% were put on the alternative. So it's always interesting to me that the doctors were actually told that there was a loss of function, but they still decided to go through and put 40% of the patients on clopidogrel. So this is the risk of adverse events for about 1 year after percutaneous cardiac intervention, death, MI, or ischemic stroke. And if you look, the lack of function clopidogrel arm had a much higher risk, had a 2.26 relative risk, and with a significant p-value, and the non-loss of function and the loss of function alternative patients were not the same. So basically, if you had a loss of function and you were put on clopidogrel, you were twice as likely to have an adverse effect than if you did not have a loss of function and were put on clopidogrel, or you had a loss of function and you were put on something like ticagrelor or prasugrel. So this was compelling data to me to either use alternative medication or to use genotype testing. And then so this is another way that they looked at. They said, well, is it just the people who are bad, the star 2s, the homozygous for the low? And actually, even if you're an intermediate metabolizer, you're at a high risk for cardiac or ischemic stroke after percutaneous. So the people here have. The people here, if they were intermediate metabolizers, so they weren't the really bad ones, but they were the ones that intermediately, they still had a higher risk compared to those who did not have a loss of function or those who were given an alternative medicine. So I think that so then you say, well, just give everybody, Brilinta or one of these other drugs. And so this was another way of looking at it. And this is just in the New England Journal of Medicine last year. And this was from these slides. The blue back slides are all from Cameron Thomas at the University of Florida. So this is another study that came out, and basically what they did is they looked, and the genotyped group had a slightly less outcome, which was basically adverse effects versus the standard treating group, but it didn't reach statistical significance. So it's really sort of the outcome here was non-inferior. So using a guided approach, of CYP2C19 guided approach inhibitor. So basically, giving people either whatever you felt, or using a genotype to guide, the outcomes in terms of clinical outcomes was non-inferior. But here's the kicker. The kicker is that the primary bleeding outcome was lower if you use the genotype-guided group. So clopidogrel has a slightly lower bleeding profile than those other agents that would be used. So if you used genotype guiding, and so if you gave people who were able to metabolize clopidogrel and were normal or rapid or ultra rapid metabolizers, clopidogrel instead of prasugrel or ticagrelor, they were more likely not to bleed, or less likely to bleed, and this was statistically significant. So the clinical outcome, the endpoint, the desired endpoint, lack of stroke or in-stent thrombosis or that sort of thing, was non-inferior. It was basically the same, but there was statistically significant less bleeding using CYP2C19 to guide your therapy if you're going to use it. So it's interesting to me. This hasn't, some cardiologists have really bought on. University of Florida has this actually at point of care testing in their cath labs. Other places have really not cottoned on to it, but I think that the data is fairly compelling, and it's something that should be thought about. So what are some of the conclusions that I have? Drug effects and efficacy varies among patients. Some of that variation may be explained by genetic differences among people. It's possible to predict for some drugs who is likely to respond and have an adverse outcomes by looking at genotypes. The use of pharmacogenomics as a tool has the potential to help us increase efficacy, lower adverse effects, and maybe save money. And there's a lot of data out there. In the next several slides, the next several talks, I think I'm going to review specific data and recommendations and just continue to talk about this. So I appreciate you watching this. Hopefully we'll get back to normal in the next academic year. We'll have another Grand Rounds in a couple of weeks, and so I intend to make those available. So thank you very much for your attention, and God bless all of you.